Good morning. At the outset, I would like friend Dr. Malay Sharma and his entire team for hosting this wonderful conference. I wish him all the best for his new hospital, the R. Everett Hospital. I'll be speaking on topic troubleshooting in EUS guided cyst gastrostomy. As we all know, cyst gastrostomy is a very common procedure and is accepted pancreatic fluid collection by EUS. There are several steps which are to be followed sequentially. Each step is linked to the other one, and if we make fault in first step, the subsequent steps will be difficult to perform. And we have just to remind everybody that these are steps that we follow when we have to place plastic stents for pancreatic fluid collection drainage. We first puncture with a 19 gauge needle, pass a guide wire inside and coil at least 1 to 2 loops inside the pancreatic fluid collection. Then we create a fistula by passing a 6-French cystotome, which is coaxial, goes over the guide wire. Then we dilate this fistula with a balloon and then place multiple guide wires inside the cyst cavity, at least 2, because the intent is often to place 2 stents. 1 stent is usually not sufficient, and these stents have to be double pigtail plastic stents. The current 5-flange metal stents or lamps which are used, and together they are called as LCMS or large caliber metal stents, are a new way to treat pancreatic fluid collections, especially walled off necrosis, which have significant debris inside. So these are several ways of the steps that we follow. There are different imaging modalities which we use during this procedure. We use EUS, we use fluoroscopy, and we use endoscopy. Other imaging are used, and which combination is used depending on which step you start off with. As this chart shows, that when we inspect or interrogate the cyst, we use EUS. When we puncture, we do under EUS vision. When we pass, we guide wire, we use EUS vision. We also use fluoroscopy. Then we pass obviously we use EUS and use fluoroscopy to the path of the cystotome. Then we dilate with a balloon. Obviously we use EUS, but we can use fluoroscopy if we inject contrast in the balloon, or use endoscopy to readjust the balloon position. And last, the step of placing the stents, we require all 3 imaging modalities: EUS to place the internal flange of a metal stent, and endoscopy to look at the second flange, which is in the lumen. Obviously, fluoro helps us in positioning the stent. In this talk, where we had challenges during cyst gastrostomy drainage and how we overcame this challenge, that is troubleshooting. Let me show you a first case. This is a collection which had debris inside, a small amount of debris, and our intent was to place a plastic stent. Soon after passing the guide wire, there's a blood leaking inside the cyst cavity. And this bleeding became brisk as the procedure went forward. Mind you, we have not used, and this bleeding became torrential. This can happen sometimes when there are a lot of collaterals in the wall, and if the cyst has too much pressure inside, it may compress these collaterals, and we may fail to see these collaterals on Doppler imaging. The moment you puncture, you can sometimes start seeing this bleeding. Often they are very tiny and small and stop on their own, but if not, then we have to change our strategy. So we changed our strategy too. We immediately switched over to a fully covered metal stent, that is a Nagi stent that we used. And this stent, which is self-expandable stent, caused a tamponade of the collateral vessel in the wall, and that stopped the bleeding. Stent from the debris which may clog the lumen. The bleeding was mild and self-limiting, and the stent stopped that bleeding inside the cyst. So change your strategy if you face any problem during the procedure. Moving forward, another case which was somewhere in the early part of our experience with metal stent, and as you can see the heading inside, salvaging internally migrated Nagi stent. So while placing the stent, we realized that stent is gone inside the cyst cavity and we cannot see anything in the luminal side. Very common in our practice. So don't get worried. I think you use your guide wire which is already. So guide wire should never be removed till you are 100% sure of your stent placement. And this guide wire will be your lifeline. So what we did was we placed a plastic stent and came out. We did not want to remove that metal stent immediately. And 2 days later, so this time we went beside the plastic stent, passed the guide wire in the cyst cavity, dilated the vessels, and then go inside. There's a little bit of pus coming out. Then we saw the metal stent just inside the wall. We caught this metal stent at the edge with a foreign body forceps and gently teased it out into the gastric lumen. As you can see on the screen, the stent comes back in position. So not only we have saved the stent, we have saved the patient, we avoided unnecessary surgery. So never panic when you have situations like this. Just place a plastic stent, bail yourself out of that crisis and come back another day after discussing your pros and cons with your colleagues and seniors. Let me share one more example. We often do necrosectomy for patients who require and procedure very labor intensive. So as you see, this Nagi stent is blocked with a large amount of debris, which is using a braided snare to remove this debris. The common procedure. But this debris was so large and it was tightly anchored inside that it dragged the metal stent out as well. So this inside the cyst cavity actually came out. So no need to worry, we realized it immediately. We went back inside with the endoscope. You see the pus coming out because it was completely clogged. The metal stent is seen lying in the lumen. Remove this metal stent, take it out, clean it up and keep it ready. Continue your endoscopic necrosectomy as we had it. So go back into the cyst cavity, use your water irrigation and flushing system, remove the debris, whatever is to be removed gently. Look for big vessels which are there. Generally, the splenic vessels are at the base of the collection, as you can see here. And then later we can replace the stent in position. I will show you how in the next case. So the stent had migrated into the gastric lumen and placed it back into the scope. So you use a regular upper GI endoscope and a foreign body forceps. Watch very carefully what's being done here. This is the Nagi stent ex vivo. See the thread there? Through the endoscope, this foreign body forceps comes out, catches the thread. You crumple the stent ex vivo and gently pull the stent inside the cyst into the lumen of the scope. Now with the whole assembly intact, you pass this endoscope with the stent loaded inside within the worn cavity. Push out the stent while pulling back the scope. And you can actually see the stent is in position now. So same stent is now being used in the patient which got migrated out. So you can pull it and replace it. You don't need the entire assembly of the stent to replace. One other interesting case which I'd like to show is a large cavity. And once we drained the stent we used, the stent actually got migrated inside. And you can see a stent lying deep inside the pelvis and the cavity is still there. So this was realized at the time of procedure. Since the guide wire is inside, we placed inside, one at the stomach, and through that we can go inside the cyst cavity, go deep inside. You can check under fluoroscopy which way the stent is. Keep going inside, you see the debris on the way. I'll move it a little forward. So you see the stent deep inside the pelvis. Grab it with a foreign body forceps and gently pull it out. So now you have one more stent to cross, and while coming, get dislodged. So in this situation, the second stent that is in the cyst-gastrostomy side got dislodged, which came out, and the other stent is still inside the cyst cavity, the first one which was in the pelvis. So that can be teased out. You see it here. You can pull it out and reposition it or clean it up and replace it. So these are some of the situations by doing such maneuvers, and continue with the neck. I'll keep moving. So this is a necrosectomy being done, and at the end of the procedure, one of the stents which has been cleaned and is okay is replaced. So these are some of the fluoro images which show how deep the wire has gone to the pelvis. You can see the stent. The first one stent is here, through which it's going down and catches the other stent here. This is the last video I'd like to share, is timely removal of these metal stents. They should be removed by 3 to 4 weeks. Otherwise, it can cause bleeding and other complications. As you can see in the video here, this is a stent which has been inside for long, and the patient forgot to come back in timely period. But still you can see the stoma, you can see the stent inside, and it's much easier to remove these kind of stent which are fully covered. But as the time passes by, the covering of the stent goes away, or sometimes the stoma can get closed, and we may lose that opportunity to remove the stent. So in the end, I would like to conclude by saying that remove all fully covered metal stents placed for ward of necrosis after a finite interval. They should not be kept inside for more than 4 weeks. If the procedure does not go as according to your plan, stay relaxed, because if you stay relaxed, you can think well and make corrections. But if you panic, you can create more problems. So be nimble-footed, change your strategy during the procedure, and according to the need, whatever is available. In case you still find difficulty, call a friend, call Malay. I'm sure he will bail you out. Thank you very much for your kind attention. This is the team which we have around who helps us when we have a crisis.
Thank you, Sundeep. Very wonderful talk. I have one question for you. And very nice to see you after a long time in this COVID era.
Thank you.
So, yeah, Sundeep, in deciding the type of stent, either plastic or metal, what are the criteria you use? Means depending upon the necrotic part and the debris in the cyst.
Yes, so that's a very good question, and the decision is made by as you said, by the debris in the cyst, the quantum of debris, the rough percentage in context to the whole volume of the cyst. So if debris is not there, that is pure pseudocyst, or it is less than 10%, our personal preference is to place plastic stent, because they will do as good a job. Unless the cyst is so big in size that we need more efficient drainage, then metal stent is used in such situation. But an average sized walled of pancreatic fluid collections, less than 10% debris or pure pseudocyst, plastic is better. Above 30%, definitely it has to be metal stent, because there would be some need of necrosectomy in times to follow. In between 10 and 30, which is again a very rough figure, and there is no way of accurate quantification, we can use either, but our trend is towards a metal stent.
Okay, and there is no indication for surgical drainage depending upon the material of necrosis.
So yes, we do take surgical opinion and seek their help. When a person has several collections, more than 2 or 3, they are far away from the stomach, and then if the debris percentage in a single collection is more than 70% or 75%. But we generally do this discussion in a team meeting with intervention radiologist also with us. And if the patient condition is supportive, then straightaway surgery is considered. But some of these patients, as you would be knowing in your practice too, that they are quite sick. And to just make them a little better, we need to drain them, and percutaneous drainage or endoscopic drainage in alone or in combination sometimes helps.
Okay, and one more concern, while doing a necrosectomy, we most of the time come across a bleeding vessel. So what are the best modality in this crisis?
So that's a very challenging scenario there. We need to have a good CT scan with a arterial phase and a venous phase up front. So that tells us if any pseudoaneurysm is there which is picked up, then we don't drain. We first tackle the pseudoaneurysm, and then after a week or two, then we drain it. But having said that, if we don't have it before and see the bleed happening later on, especially at necrosectomy is a very dangerous procedure. It should not be done easily like a routine endoscopy. We should be ready with all these things with anesthesia support and in a theater. It's a time taking procedure as well. It can easily take from half an hour to 1 hour. And the purpose of necrosectomy is to tease out or remove those thick debris which is adherent to the wall. Debris can be loose also. So that loose debris, if they're large, you can remove it piecemeal. That's okay. But the one which is adherent to the back wall of the cyst is quite dangerous because we do not know endoscopically what is below that debris. And accidentally, if we use any sharp instruments like a foreign body forces, we can actually injure the blood vessels. So use your water jet, use a snare. My personal preference of the device is a braided snare and not a rat tooth forceps. And if it's too much adherent, I give it up. My threshold for aggressive and necrosectomy is very less. I would not do that. I will put a nasocystic tube, irrigate it with saline, wait for 2-3 days. Most debris would get loosened out, and eventually you'll be able to take them out. It's only a matter of time. So never be in a hurry to do these procedures. That's my suggestion to everybody.
Okay, and what about the use of hydrogen peroxide?
Yeah, that's an interesting thing. So hydrogen peroxide is used when the debris also is infected. So you see frank pus covering the debris element, and that's also quite thick and not getting easily washed out. And if the patient has sepsis, that is fever and counts are high and CRP is high, so in that scenario we use hydrogen peroxide in the percentage of 3%, and we use it with combination of saline. So what we do is, it's look, so this lavage is generally saline in 90%, and 10% we use hydrogen peroxide, and this is given as a bolus uh, at the bedside in the room when the patient has the nasocystic tube inside, about 10 to 20 cc depending on the cyst cavity size. About 15 minutes later, then we rush a bolus of saline. We don't mix together the hydrogen peroxide and saline, because hydrogen peroxide, once it gets open, it becomes water and oxygen. So that becomes waste. So let the hydrogen peroxide work on the debris, and later we irrigate with saline.
Okay, fine. Thank you.
Yes, sir. Morning. That's an excellent presentation. This is Vishnu from Global. Sir, just one question. In a rescue situation where we puncture and plan for a plastic stent, if there is a bleeding, we put a metal stent to give a tamponade effect. So the question here is, what is the next plan of action? When do we go for the removal of assessment of the bleeding? Do we have to take a CT and do, or do you preemptively ask your IR guy to go and coil the vessel which is effectively bleeding?
So the bleeding can occur from two sides. One is the entry point bleed, as shown in the first case that we showed. That gets easily controlled by this metal stent. But the bleeding can also occur from the back wall of the cyst where the vessels are there. And the pressure inside the cyst was keeping that bleed abated. That means the bleed was controlled or was not happening even if the wall was thin. But sudden release of pressure when we drain these collections using a metal stent reduces the pressure inside the cyst, which was compressing this vessel in the back wall. If that happens, that means it's an arterial bleed in all probability, and then IR has to come in. So your clinical monitoring would tell us if the BP suddenly drops and tachycardia happens and you see the blood coming when the procedure went off well, means that the bleeding is happening from the other end of the collection at the time of drainage. Other time of bleeding, as Uday was discussing just now, will occur when the necrosectomy has been done, and that you would immediately recognize on the table. And if it's an artery, uh, even the small veins often stop, but if it's a big bleed, people have used clips endoscopically to do that. but I'm a little hesitant in using it. I would prefer an IR intervention, because if it's a big splenic artery and you clip it up, you actually cause a splenic infarct and then complications associated with that. IR people can do a much better job than us.
Thank you, sir.
Okay. Then I think we'll stop here. Nice to interact you and nice for this whole discussion. Thanks a lot, Sandeep.
Thank you, Uday. Thank you.
Thank you, sir.